All right. Good afternoon. Today is March 11th, Friday. This is United Medical ACO. My name is Kamal Erkan. I am here with Sean Donovan. Sean, how are you doing?
Not too bad. How are you doing?
Good. So our weekly event, trying to give updates on healthcare news and different things happening with healthcare and in our society. We do have a clinical presentation today. One of our United Medical Clinic providers is going to join us, and then we have some other discussions. So what we'll do is we are going to start with our COVID updates. Sean.
Yeah, so again, we always kick it off with our COVID updates, as you said. Looking here with our graphs, we're still seeing that super sharp decline in overall cases and hospitalizations for the U.S. So again, the U.S. is no longer in that top five, as we normally used to see in the past. They were consistent in the top five, so we're actually remaining out of the top five, which is pretty good. Case-wise, like I said, we have a super sharp spike downward as we expected moving into the springtime here. We kind of saw this in trends over the past few weeks, and it's definitely continuing to remain low. And then vaccination-wise, we are having around 2 million more, still keeping that pace each week moving forward, new vaccinations. And then comparison on the state versus nationwide level. As a whole nation, we have 216.5 million people now fully vaccinated. And in Delaware, we're at 62.5%. These seem to be steadily increasing by about 0.2% throughout the state of Delaware each week across all of those different age categories, respectively. And then just to touch on the booster, we're almost at 100 million. So we're at 95.5 million people nationwide having received a booster shot.
So I guess at this point, we were expecting numbers to go down. So although I think this weekend is going to be kind of another winter storm, right?
Yeah, so this weekend coming up should be getting cold again. And also with the St. Paddy's Day, another large holiday where a lot of people are moving around, interacting in large crowds. So those two things combined coming up in this next week or so, might see a little spike.
Do you still have family members who are not fully vaccinated, Sean?
I believe there are a few still in our extended family, but the people that I'm around down here in Delaware, we are, so that is good.
So you have a lot of siblings, right?
I'm the youngest of five. Save the best for last.
Yeah. So that's not a lot. That's okay. So the booster is going to be the most important part of the vaccination process, and we're hoping that people would listen and they would follow our recommendations. So, and hopefully more people will be ready for by getting their vaccination, and if they didn't get their first and second shots, getting those, being ready for the fall season. So if COVID is going to be another flu type, it's going to impact our lives in 2022, 2023 season. So it's not going to go anywhere. So we really need to, we have to try our best to fight back. Mm-hmm. And we do have good tools to fight right now. So it wasn't the case maybe 18 months ago. So, all right. So I know that last night when we have our provider meetings, Anthony did update us. So we are, from Delaware standpoint, we are almost up to date with, like we were able to catch up with the average United States numbers. That's the case, right?
Yeah. So yeah, we touched on that a little bit last night, how we're closing that gap between nationwide and as a state. So that's good to see. Yep.
Good. So, well, Today, we have our clinical presentation, so I do want to actually let them in first, so then we can have, since Jacob has office hours, I want to make sure that he's able to go back to his office hours. So they are waiting right now. And also Donna Glankel. Hey, Jacob, how are you doing?
Hi, Carlo, I'm good. How are you?
Good. Donna, how are you doing?
Very good, thank you.
All right, so I am gonna go us up here. So then, okay. Oop. So, Jacob, thank you for being with us. We started, as you know, we started having these clinical presentations. Our patients are watching this, other people are watching it, and each time we have, every other week we are doing this. Don and I, and you are part of the clinical case conferences that we have in the beginning. Now you are busy with the patient hours, so then we haven't seen you for a while. So today we are going to discuss diabetes, maybe one of the most common chronic illnesses. So we want to kind of hear from you from the primary care setting, and if you can actually briefly introduce yourself, and then after that we can just discuss from the primary care setting what diabetes is and what patients should and should not do and how we can help them.
Mm-hmm. Yeah, sure. So hi, my name is Jacob Heiser. I'm a physician assistant here at United Medical. I started here at the end of October of 2021, and it's been going really well so far, and I'm excited to talk about this topic with everyone.
All right, so Donna, from our case conferences, I guess the most commonly seen diagnosis is diabetes with some other chronic illnesses. So I think it's now timely to just discuss this now, although this is our second event this week. Dr. Ripo Handal was with us on Wednesday night. So although everyone is talking about diabetes and everyone knows about diabetes, still this is the most common and maybe most maybe under-diagnosed conditions, because we see it from our bariatric case conferences where patients don't know that they have diabetes. If I have to tell you, like today's Friday, this week, maybe at least 7 patients whose A1C was over 9. And they did not know. One of them was 12, one of them was 13, one of them was 11. This was the first time they met their A1C number. So, and this is not being treated properly or timely. So, Jacob, what do you have to tell us?
Would you like me to go into the presentation aspect, or you just want to discuss it a little bit?
We can actually give the background, and then we can start with your presentation, and then we can discuss more.
Okay, sure. So just a little bit of, initial background. Like you mentioned, diabetes is one of the most prevalent issues in our country. I do have some statistics about that in the presentation, but it's something that we certainly see a lot in primary care. It is something that we do handle for a while until things can become very out of control, at which point we would bring in some specialists like an endocrinologist or potentially nephrology, neurology, and ophthalmology for the complications that can arise. But this is something that we really need to be screening for and educating on before it even happens, because there are a lot of Americans who currently have what's called prediabetes, which is the precursor to being diagnosed with diabetes. And that number is much, much, much higher. And it involves a lot of people in the country, but something that is very preventable. We typically don't do any medication for people with prediabetes. We just preach the things that are always talked about with good health, which is going to be diet and exercise.
I'm just going to jump in for a second. So speaking of that, here at United Medical ACO, we also have an accredited diabetes and nutrition program. So we have registered dietitians on staff, and they do see patients with prediabetes to help them with their diet so that hopefully they can prevent actually having full-blown diabetes.
So if you want to go back to the first slide, I'll just discuss a little bit more in depth about.
So with the Jacob, with the format, so the video is just running on its own.
Okay.
Yeah, we'll just speak on. I can, if you don't have them, I can bring it up.
No, I can pull mine up. It's just over on my other screen here. Okay. So just going off something that I talked about a little bit earlier. So diabetes, just to give everyone a general definition, is the disease of inadequate control of blood levels of glucose, which is sugar. So most people know diabetes is related to your sugar levels. There's many different kinds, but the most common are type 1 and type 2. That's mostly what I'll be talking about today. Other types include gestational, neonatal, steroid-induced. These are very rare. Most common by far, type 1 and type 2. Type 1 accounts for about 5 to 10% of all diabetes, with type 2 being the vast majority of about 90%. So from the current statistics from the CDC, there's about 37.3 million people in America right now who have diagnosed with diabetes. But about 1 in 5 people currently don't know that they have it, which is something that you mentioned, Kamal, is that we have a lot of people who have diabetes that don't even know about it right now. So the other important thing I mentioned was prediabetes, which is about 96 million Americans. That's about 1 in 3 adults in America currently have prediabetes, which I'll talk a little bit about the diagnosis side of that in a bit. But that is a huge number and something that is modifiable with the things that we'll talk about a little bit later. And with this being a primary health concern, primary care providers focused, it costs a lot of money to have diabetes. So according to the American Diabetes Association, in 2017 was the most recent data I could find. They estimated that the total healthcare cost of diabetes was $327 billion. It's likely that that number has increased over the last 5 years, and it will probably continue to increase given the fact that we have this obesity epidemic, and that is a large cause of diabetes. So just moving a little bit into type 1 and type 2, just for some more educational purposes. Type 1 diabetes is caused by destruction of beta cells in the pancreas. So when we eat sugar, our blood glucose levels rise, and the pancreas produces insulin, which is a hormone that's responsible for taking the sugar out of the blood and moving it into the cells, therefore decreasing the level of sugar that's in our blood. Now, these beta cells in the pancreas are responsible for producing the insulin. And what happens with type 1 diabetes is typically it will be some sort of autoimmune process where the body attacks itself and attacks its own cells, therefore destroying the beta cells. And now the body cannot produce any insulin. And if you can't produce any insulin, there's no way to reduce your blood glucose levels. So typically this process can take multiple years to occur. Usually it will start from birth with an autoimmune condition, but the incidence rate is typically found at ages 4 to 6 and then into early teen years, about 10 to 14. And that's just due to taking time for the beta cells to be completely destroyed. And these patients, once they are diagnosed with type 1 diabetes, they require long-term use of injectable insulin to prevent episodes of hyperglycemia where they have high blood sugar. Just a little fun fact about type 1 diabetes, Nick Jonas actually has type 1 diabetes. He was diagnosed at age 13. Now, type 2 diabetes is the most important one that we'll probably talk about today. This is about 90% of all diabetes cases, and it's been on the rise over the last 20, 30 years. It's due to insulin resistance and an inadequate supply of insulin. So because of the obesity epidemic, taking in high amounts of sugar, large amounts of fat, the insulin in our body becomes resistant to the sugar, and it doesn't work as well as it used to in terms of decreasing your levels. And also with just too much sugar, there's not enough insulin. It can't produce enough. Now, this is something that used to be seen in older adults, 40s, 50s, after long, long periods of time of inadequate control of sugar. But with the diet and problems that we're seeing today, it actually is being seen in a lot of younger people. And we can see people diagnosed with type 2 diabetes in their mid-20s. So that's obviously something that we're working to combat against. And that's because it's linked to a high sugar diet as well as obesity. And then finally, there is also a large genetic component with type 2 diabetes. Typically, anyone with type 2 diabetes will have at least one parent that also has type 2 diabetes. So moving on to some signs and symptoms of diabetes for people to be aware of. The problem with diabetes is that a lot of times it can be silent. Elevated levels of blood glucose in the body do not always have symptoms, especially if you're in the pre-diabetes category or even low diabetes ranges. That's why we need to do, screening and education. However, long periods of time with very high sugar can lead to, I like to call them the polys. It's polyuria, polydipsia, and polyphagia. And what that means is polyuria is urinating very frequently and urinating large amounts. Polydipsia is excessive thirst, and polyphagia is excessive hunger. Now, with this excessive hunger, you'll be eating a lot, but you're still going to be losing weight. With the excessive thirst also comes dehydration. You can also have a bit of a fruity odor from your breath because you're actually breathing out the glucose. Another thing that's a little more rare but can be seen is something called acanthosis nigricans, which is where you'll get dark velvety patches of skin. And in females with high levels of sugar, they can complain of frequent yeast infections. Now, something I mentioned earlier, there are also long-term complications of diabetes. Those are symptoms that you would have from these episodes of high blood sugar. But if you have those levels for a long period of time, you can have retinopathy, nephropathy, and neuropathy. Retinopathy being disease of the eyes and the blood vessels in the eye. Nephropathy being disease of the kidneys. Diabetes type 2 is the most common cause of chronic kidney disease in America. And neuropathy, which is disease of your nerves. Typically, this is found in diabetics in their feet, which is why we recommend seeing a foot doctor if you have diabetes, because you can get nerve damage in the bottom of your feet, leading to ulcers, tissue damage, and pain. So from the primary care perspective, what we like to do in terms of diagnosing and treating diabetes is we have to screen. The way we diagnose pre-diabetes and diabetes, there are 3 different ways we can do it. The first is a fasting glucose. This is taking a sugar level after you haven't had anything to eat or drink for at least 8 hours. That level for pre-diabetes would be 100 to 125, and a diagnosis of diabetes would be a fasting glucose of over 126. We can also take a random glucose, which is a blood glucose measure at any time in the day, whether they've had anything to eat or not. Pre-diabetes would be 140 to 199, and random glucose would be over 200. Then finally, we have our hemoglobin A1C. This is probably the best marker for diagnosing diabetes, in my opinion. The reason being is that hemoglobin is a protein that's in our blood that carries oxygen. And this protein can have sugar attached to it if there's a large amount of sugar in the body. So what the hemoglobin A1C does is it measures the percentage of hemoglobin cells that have sugar attached to it and gives you a percentage. So for pre-diabetes, an A1C of 5.7 to 6.4% is pre-diabetes. And then for diabetes, it would be an A1C over 6.5%. This is something that we use to not only diagnose diabetes, but also to monitor. We currently recommend getting 2 A1C measurements per year, about every 6 months, potentially every 3 months, depending on how well controlled the diabetes is. And the reason that we do it every 3 to 6 months is because hemoglobin being part of your red blood cells have a lifespan of 3 months. And so this gives us an idea of what the sugar levels have been over 3 months rather than what someone's fasting or random glucose would be, because that would be over the last couple days or so. You can sometimes have a glucose level that's a little bit elevated if you had a high sugar dessert, 10 hours before your fast. That can sometimes affect it. But with a hemoglobin A1C that gives us the best reading of sugar. So our decision to use these tests is very much based on symptoms. It's based on family history, like I mentioned with the genetic component, and also our screening recommendations, which I'll get into a little bit later. So once we move into someone who has either prediabetes or diabetes, we have to start treating. It's best to be very empiric and very quick with this. Typically for prediabetes, we recommend a low sugar diet and exercise. Like most preventable chronic diseases such as high cholesterol, high blood pressure, it's very dependent on our weight, our cardiovascular fitness, and our diet. So for diabetes, low sugar as well as low fat can be very beneficial in reducing sugar levels, and exercise. Once someone has diabetes, we typically move on to at least one form of medication. There are a number of different classes of medicine that do treat diabetes. I won't get into those too much today. It's a little complicated, but one example, for instance, that is typically our first line is metformin. It's a really good medicine that works well and doesn't have a lot of adverse side effects. If someone is failing on metformin or they can't take metformin, we can try other medicines. We can usually do up to 2 or 3 medication classes to try and reduce the sugar levels and reduce the A1C. If that is unsuccessful, then we move on to what the type 1 diabetics are using, which is daily use of insulin. We have long-acting, short-acting insulin, and this is typically, as long as it's adhered to, is very beneficial for our patients. The other thing that's very important for our diabetic patients that someone I mentioned is the possibility of retinopathy and neuropathy, which is why we recommend at least yearly foot and eye exams. So finally, moving on to our screening and prevention. This is where I try to help my patients discuss this before it even becomes a problem, is trying to prevent this before it happens. Currently, the U.S. Preventative Task Force Service recommends screening any person 70 who is overweight or obese, meaning that their BMI is above 25. If these results are normal, it's recommended to rescreen every 3 years. Now, typically what I do as a provider, every physical, I do get a fasting glucose because I get a metabolic panel because I'm checking for other things such as liver function, kidney function, electrolytes. That's a good way to get an initial screen for us, is to just get that fasting glucose. I'm not getting an A1C on someone unless they have prediabetes or diabetes or symptoms. But as far as prevention goes, I always encourage exercise, healthy diet, well-balanced diet, whole grains, complex carbs, trying to watch sugar and sweets, things like soda, apple juice, and simple carbs like white rice, white bread, white pasta. Those are very easy to add up and increase our sugar at very alarming rates. So it's important to educate, like something like we're doing today, on the causes of diabetes, how it works, how it presents, and what we can do to stop it. And then part of my slideshow here, I do have a link from the CDC website, which is to the CDC National Diabetes Prevention Program. That's a really great resource with a lot of information from the CDC. And then for our patients in particular, like Donna mentioned, we do have our diabetes nutrition group. We do recommend nutrition counseling for most of our diabetic patients because it can be very useful. I've had many patients who tell me, oh, it was great to talk to them because they told me things that were a little more complex and I never even thought about, such as eating, less than an hour before bed or something like that.
All right, so what's been happening in the last 6-7 months? Donna and I, we get up. We don't get up together, but we get up and then we start the CADES conference at 8. So 8 is not my popular time. We have our nurses. We have a couple of our business development members, Kim, Sean, they are part of the CADES conference, Hazel. So we have new patients being presented to us. And then we have our follow-ups. And then we have, on Thursdays, we have our patients with behavioral health who may need special support for getting their appointments with behavioral health providers. So now diabetes, because well, I'm not a physician, but it's almost now 22 years I've been in the medical field. And then because we are in this every day, in and out, at a certain point, you kind of start learning. In the last 10 years, it was on the clinical side more because what we have been doing is the population health management. Now, so interesting enough, if you live in Russia these days, so you don't need population health management because United States, we banned McDonald's and Coca-Cola and Starbucks. So then you don't need population health management, and probably that helps diabetes as well, right? So, but here in United States, we have access to food. So, today is my wonderful executive assistant Anne's birthday, and I came to my office and I have a beautiful plate ready to go. Actually, there are two of them. So now I've been on a diet for my entire life, and I'm going to probably eat this after the session. But the food is always a struggle. So the access, not because we don't have food, unfortunately, there's too much access. Now, a couple of the things that I want to point out. One is, Jacob, you were in some of those sessions with me. The interesting relationship diabetes have with the depression. After we see so many patients who have also depression, that's coming from those uncontrolled, unmanaged diabetes. Patients with high A1Cs, they also have chronic depression. Patients with morbid obesity or obesity, it's one of the root of the problems of the diabetes. Chronic kidney failure, cardiovascular issues. So this problem is not by itself. It's not just someone has diabetes. So my mom actually has diabetes, and they were visiting in January, and just managing the medication is requiring a lot of attention, and the timing of it, how many she's going to take, which one she's going to take. And in some cases, they have side effects. So the point where I'm going with this one is we do have an accredited organization on the diabetes side with Amy Wilkinson and with our other dietitians, with Donna on the clinical side. And there's a little bit hesitation for patients utilizing that service. And because unless you don't have enough proper help, managing this disease by yourself is going to be a challenge. So, and you give us the background of this disease and how many people are dealing with this. Many people don't even know that they have it. They just deal with the symptoms and they think that it's going to go away, and then they don't get tested in a proper, in a timely manner, and then all of a sudden they have a uncontrolled diabetes. They start with a high dose of different medications with several of them. It's not just one. So it becomes a bigger battle, and this is preventable. You can manage this. Our providers are available, and we want to make sure that our patients are able to take advantage of these. Annual physicals are the great time for us to do the screening. So for young patients, well, I would consider myself in the young population, but like I go to the doctor once a year, and that's for my annual physical. Well, that's, I didn't do my blood work this year yet, but I have to. So this is the only way that we can actually get a better idea. So we want to make sure that our patients, when they receive emails, Jacob, as you know, we started these standard emails from our business database, just so that we can actually get our patients' attention. when I see someone with actually, in fact, I just got a message from Dr. Handal because I requested him. He has his office hours just for our ACO patients on a Saturday. And I have a patient with A1C10, and this patient needs to be seen. And I was asking him this is my second week in a row, if we could add someone. And now I'm hoping that Melissa is listening this session, so I don't have to text her back, so she can confirm with that patient. So he's adding this patient to his Saturday schedule as an add-on. So really, like we are trying to go out of our way to be available for our patients with the providers, with our nutritionists, with the program itself, with our care managers. And I'm hoping that we can have more people listen to what we have to say and then follow what you guys are, the care that you are providing. Donna, anything you would like to add?
Just a little add-on to that, Kamal, all the other resources we have. So just like this particular webinar, we have the Wednesday Wellness webinar. So we have had a variety of providers and specialties. We've had endocrinologist, of course, Dr. Hundel's on there several times a year, but we've also had a podiatrist, an optometrist, a nephrologist, a cardiologist. So we bring on all the specialists to talk to you about the interaction between those particular organs and diabetes, or the importance of getting your dilated retinal eye exam or your foot exam, as Jacob mentioned, annually, so that if you do start having issues that we can, work on the prevention before it's too late. We have a website. We also have our YouTube channel. So we have a lot of handouts about, diet, helping you with shopping tips, helping you with some meal planning. We also have quick tips that Amy has done, and they're on a variety of topics from treating low blood sugar, how to use your glucometer, meal prep, meal planning, shopping on a budget. So we have a lot of resources through our program on our website and on our YouTube channel. So we just want to make sure we get that message out there. So, again, it's just other resources for patients to use when you have the time, to listen or review the information.
Thank you. Jacob, thank you for being available. I know you have office hours still, and you probably still have more patients to go. Anything you would like to add before we close?
No, not really. Just, I think you guys hit on some really good points with what we're doing to try and, work on prevention. Like you said, this is very much a preventable disease. At the very least, even if you have very heavy family history, it's very possible everything that you do could still lead to you getting diabetes. But that means that if you do everything that we want you to do with the low sugar diet, the exercise, taking care of yourself, you can really delay that until you're much, much older. Whereas, right now we're seeing a lot of patients that can get diagnosed in their mid-late 20s. And the other thing that I just wanted to touch on as well that you mentioned is please, everyone, attend your yearly physicals. At the very least, we want to see you once a year, because that gives us a great opportunity to check in on you, do your screenings, get your blood work. A lot of these things, like I mentioned, it can be very asymptomatic. You won't have any symptoms, even if you have pre-diabetes or early diabetes, where your A1C is, 6.6 to 7, something like that. And that's something that we'll only find by doing our screenings and doing our lab work. And it can be difficult to get those things done when you come in for a more acute visit, like not feeling well, back pain, stomach pain, something like that. We really want people to be at least attending their yearly physicals, so that way we can make sure that we continue to screen and prevent this.
Excellent. Well, thank you so much.
Thank you very much.
Thank you.
Sean is back, so
I'm back.
and so is your cartoon is back.
Oh, yes. We do actually have some cartoons this week. So again, with everything going on in Europe, kind of a war going on, we do have the cartoon involving the gas prices with the European Union, kind of a little bit irony in there, saying that we're going to run you out of business as they're buying their oil from Russia. And then you see on the right-hand side, there's people are trying to finance and take out a loan to afford to fill up their car with gas. So just hitting on the super spiked gas prices with the oil crisis going on.
Yeah, the sad part of this is, we've been telling people, and sometimes I hate repeating myself, but there is no other way to make yourself clear. People don't listen. They just don't listen. So they think that you think that they're listening, but they really don't listen.
Mm-hmm. Right.
Now this war is going to have an impact on us. Why are we discussing this in this setting? This is a healthcare topic. Well, what we do is population health management. So when there's a war, and when people are worried about the economy, and when people are actually worried about everything, just survival, and being able to have access to certain things, worried about their loved ones, this is gonna have an impact on you, on me, on everyone. And now, it was 3 weeks ago, I was talking about the oil prices, and it was going to be 125 to 150, and I think now we're already getting to 150. So
I know there's some talk of it even getting into the 200s and possibly low 300s down months from now if this crisis isn't kind of improving. But like you said, there's always warning signs and kind of predictors on what's going to happen. Like you said, it was weeks ago and we saw it happening, and it's kind of unfolding, similar with our COVID results that we always see, how we kind of predict and the trends of things happening. And there's definitely a reason behind certain factors and things happening that we definitely need to pay attention to.
So hopefully now, this, in a jokingly, we did say that Russia doesn't have to do population health management. Now, population health management was, when I was actually teaching at Golden Beacon College, this was my a part-time hobby. I designed the healthcare. Actually, it's good that we haven't talked about that for a while. I don't know if John Donald is watching, but he used to hate Thursdays because I used to teach on Thursday nights. And the Thursday, for the entire day, they would actually help with the class. They would participate in some of the presentations. So it was a very dynamic setting. So this was a healthcare class, the healthcare concentration for business students. So there were 4 courses. I designed all those 4, and I did teach 3 of them for 2 years. Not only John, but I think a couple of the other people were also hating Thursdays, but they were also enjoying it. So that was one of those things. But it was getting too much with my schedule and all that. The reason I'm mentioning this is because population health management, when we were using that time, it had this, it felt kind of like fake. Like, I'm like, I have to read this so many times. Why are we saying this? Is this the right way to say it? And not everyone was using it. It was too fancy. Mm-hmm. And then we said, okay, well, we are going to do it. So it's 2009, 10, 11. So then ACO started 2000. First ACO went live on 2016. So that means prior to that, it's 7 years that we had that work. So when the teaching started, also the initial work for the ACO started. Actually, one of my students from that first batch, she's one of our office managers even today, Natalia Zabarsky. So population health management is what the aim for the population health management is trying to get your population healthier. The healthier is no McDonald's, healthier is no soda, healthier is mindful eating, healthier is exercising. So when I heard about this sanction in Russia about the McDonald's and the Coca-Cola and Starbucks, I was like, because this is our, this is what we do every day, like population health. I'm like, oh, they don't need United Medical ACO in Russia because they are going to be healthy. I mean, that's just a joke, but maybe not a great joke, but it's a joke. So I think it's funny. So again, this entire war is going to impact all of us from different. Now, we did prep. The Art of War, it's a book that we mentioned. I'm going to go ahead and share the